I'm Dr. Raj Sundar, a family physician and a community organizer. You're listening to Healthcare for Humans, the show dedicated to educating you on how to care for culturally diverse communities so you can be a better healer. This is about everything that you wish you knew to really care for the person in front of you, not just a body system. Let's learn together. On this podcast, we talk a lot about culturally responsive care. Usually that conversation centers on ethnicity, race, and language. But I've been thinking lately about another dimension of culture that shapes health: geography. Literally, where are you in place in a country? I grew up in North Carolina. I stayed connected to some of the rural communities there. And the more I sit with it, the more I recognize that rural America has its own culture, own values, own rhythms, its own relationship to institutions like healthcare. Somewhat obvious to say, but when we talk about meeting people where they are, we have to include the 65 million Americans who live in places where the nearest specialist might be an hour's drive, where the local hospital closed its maternity ward years ago, where healthcare just feels like something designed for somewhere else. Here's how I think about making change in healthcare, whatever the topic is, including rural healthcare. There's a micro level, what happens in the visit, in the room, between you and your patient. We talk a lot about that because it's practical to me when I see my patients. Then there's the meso level, somewhat public health terms if you heard of this, which is your clinic, your health system, the policies and practices that shape how care gets delivered in your organization. And most of us are part of these large organizations now, although you might still be seeing patients or be part of very small systems, which still exist. Many are contending with these large organizations, and you're trying to design systems that's better for your patients, or at least advocate for them. We've explored that too. And sometimes we have to zoom out even further. Sometimes the barriers our patients face aren't things we can solve in the exam room or even in your institutions. You try to do it and they say it's bigger than us. It's policy, it's a rule, it's the resources. Sometimes the change has to happen at the state level, at the policy level. And that's where today's conversation lives. I want you to know that mechanisms exist to turn community voices into policy. Real mechanisms. Organizations doing the unglamorous work of listening to people, believe it or not, and translating their experiences into language that moves legislators, and tracking whether promises really can become reality. So this episode is about one of those organizations. At the health conference in Las Vegas, I connected with someone from United States of Care. They were founded in 2018 on a straightforward premise. If you actually go out and listen to people, not lobbyists, but everyday people, you find surprising agreement about what's broken and what needs fixing. Their work is translating those listening sessions into state-level policy campaigns. Today, you'll hear from Lisa, who leads their federal policy work at United States of Care and brings a perspective of someone navigating healthcare as a mother, as a daughter, and as someone who's experienced the system's friction points firsthand. And you'll also hear from Kelsey, who grew up in rural Kansas and carries a social worker's understanding that the person in front of you is rarely dealing with just one problem. And this is all in context of the Rural Health Transformation Fund. Approximately $50 billion flowing to states over the next 5 years. Right now, states are grappling with what to do with this. And you'll hear about how states like Washington are engaging tribal communities because what did you think of when I said rural health? And you'll discover practical ways to engage in health policy. And what does that look like? The goal isn't to turn every clinician into some kind of policy wonk. The goal is just to understand how all the levels connect. And what happens in the exam room is shaped by clinic policies, which are shaped by reimbursement structures, which are shaped by state and federal decisions. It's all connected. Here's Lisa and Kelsey from United States of Care. Kelsey, Lisa, great to have you on the show today. Tell me about yourself and the work you're part of right now.
I'm Lisa Hunter. I'm the Senior Director for Policy and Advocacy at the federal level at United States of Care. In a nutshell, I came to this work being passionate about policy and really seeing policy as the lever to make large scale change and fix what's broken in our healthcare system. And since coming into this from a career standpoint, I became a mom, had lots of interactions with the healthcare system as a mom, both as a patient and as somebody who is looking after two small children, also engaged in the healthcare system. I now find myself in the sandwich generation, which means that I am also observing my aging parents and their experiences in the healthcare system. And so that's what brought me to this space.
Yeah, amazing. I think of how you realize the shortcomings of healthcare by experiencing it. You go through one visit and you're like, this is what people are getting out of this $1 trillion of investment that we make in healthcare. Thanks for sharing that.
Yeah, absolutely. I can share. So Kelsey Wolfcool, I am Senior State Advocacy Manager at United States of Care. So I serve on our state policy and advocacy team, supporting our state partners in moving policies, individual and unique to their own state's needs. I have a social work background, and the thing that really drew me to this work is throughout my kind of social work beginnings was taking a look at and dealing with folks very much on the individual level. It became very clear to me that folks who were struggling with accessing both healthcare through mental health services and generally all these other social determinants of health that are leading into them sitting in front of a social worker in one way or another really struck me that there is a bigger issue here. So what I am looking towards is how could I do more of that upstream work or that more preventative work that could help make this really broad change for many folks rather than just the individual who might be sitting across the room from me.
Thanks for sharing that journey. I would love to hear about United States of Care as an organization, of how the work is done and what your theory of change is to making this a reality for folks.
So United States of Care is relatively new to the scene. We were founded in 2018, and we came about at a time right after Congress had taken another whack at a repeal and replace of the Affordable Care Act effort. And there was a recognition at the time that there needed to be a less partisan voice at the table on behalf of people and patients in policy circles and in circles that are by and large driving the healthcare system from the federal perspective. And our organization was born out of this very novel theory. If you just go out and listen to people in the country, truly listen to them, interviews, community conversations, focus groups, etc., and you ask them what your experience is with the healthcare system, what do you desire to see in this healthcare system? What are friction points for you? What are things that you believe are common sense solutions to make healthcare better for you? What you'll find, and what we've found in our listening work, is that there's quite a lot of agreement about the symptoms that are really problematic in the healthcare system. And there's a lot of desire for the same solutions, making it simpler, making it more navigable, making coverage more accessible, more affordable, et cetera, all of these things. And if you can go on and listen to people across the country, identify these common themes and translate them into policy solutions, our organization takes those insights and we drive those policy solutions into state campaigns that Kelsey and her team oversees. And then I take those policy solutions and I get them ready for federal uptake, whether through congressional action or through HHS and administration action.
Amazing. And I think the idea that people have things that they're agreeing on seems surprising for folks, when I think that's the reality on the ground, especially around health, of what people desire out of their own purpose and goals for health, but also the healthcare system and how they can be supported by the healthcare system. Has there been any recent policies that you've worked on that has been successful and that is maybe a good example of this in action?
Yeah, I can definitely talk through a couple of successes that we have seen recently. A lot of the work that we have been doing, being responsive to what we're hearing folks share our challenges that they're facing, is working on how do we lower healthcare costs and make healthcare more affordable for people. Healthcare is one of the biggest buckets of spending for families outside of basic everyday living needs. The next big thing after your rent and your utilities is healthcare, sometimes over groceries, sometimes over transportation. And what we have seen this past year, especially, is states really identifying healthcare as a challenge, both as healthcare premiums are increasing, folks continue to have higher rates of medical debt. And that has really translated into several campaigns at the state level, especially, to take a look at what are the drivers of this increased spending and how are we continuing to year after year pay more for our healthcare. And so one of those big things that passed this past session in the state of Washington actually was a bill that implemented reference-based pricing. And so recently there's been additional opportunities for states to be looking at how do we pay for healthcare differently. One of those being the Rural Health Transformation Fund, which was included through the One Big Beautiful Bill Act that passed, or HR 1, as it's known, that provides a lot of opportunity for states to take this and run with it. And this idea of we need to change how we're paying for healthcare to, in turn, change how people are experiencing their healthcare.
That's great. Do you find that there's a large gap between what patients are seeking and what's possible? As a clinician, I interact with a lot of patients and some in the community who are wanting healthcare covered. We're still trying to solve. On the constraints around solving that is quite difficult and why it's expensive. So how do you go about bridging that gap, say, from what patients are vocalizing to reference-based pricing, which can be very wonky and you're getting to the policy level of this is a solution that could be helpful. And then a feeling of feeling heard and seen is that you close the loop with them of, say, United States of Care brings up their voice to their state legislature and they said, this is the policy we're implementing. And then people want to see the change, but also feel like, oh, that's exactly what I had told them. I know not everything was possible, but they've made this change. But that seems hard in the current environment. So with that example, I'm curious, were you able to close the loop somehow with people who shared their voice? And then you're like, this is what we advocated for. This is the end result.
Yes, absolutely. I would say in that policy area specifically, one of the most influential and maybe pivotal things for especially legislators or other policymakers who have a million things on their plate is one of their constituents coming and saying, hey, this is a real issue that I am facing and here's how it impacted me. And so that was very influential on even these more kind of wonky policy areas. And so our state partners that we work with oftentimes have vast networks of consumers, business owners, other providers that are seeing the impact of healthcare challenges, similarly to how you shared with not being able to either access care or the cost being a burden or whatever that may be. And so there was a great mobilization of folks to come forward and say, this is my experience and this is how this is impacting me. And the legislature was then able to look at that and say, okay, here's a solution that we can offer to help bring some of these experiences down. And so in doing that, with all of these excellent folks sharing their stories, I would say that there's two parts to the follow-up there. One is folks are continuing to stay engaged. So as we know, there is not a one-size-fits-all policy to just make a legislation and everything gets better. And so there are continued opportunities that folks are continuing to engage in, which I think is really valuable. And it can be a slow process change in the healthcare system especially. So keeping those touch points with folks they might not see it change all at once. So maybe a policy is implemented over 5 years. And so making sure that our partners especially are staying connected with the folks in their cohort of advocates who are coming in and sharing their experiences to, one, address the challenges that they could still be facing while this is in process, and two, also give them their flowers and share the impacts of the wins, even if they might seem really small.
That's great because I find that trust is not a renewable source and that you can only work hard to get it. But once you lose that trust, it's really hard to get it back. It's a good transition to talk about, I think of diversity as both race, ethnicity, but also can be location-based. And there's a lot of intersections there too. We know statistically that rural health is an important topic in itself because so many health conditions are worse there, but including some of the metrics we think about a lot with mortality, morbidity, etc. In that
area, we have the Rural Healthcare Transformation Fund. Please tell me a little bit about that and what work you have been doing around it.
And to piggyback on the conversation that we were having around circling back and making sure that people are a part of the process and how do you keep them engaged, transforming rural healthcare is going to take a lot of effort and a lot of time, because I think we as a nation have really fossilized a way to pay for healthcare that may not be totally rational in every single community across the country, to put it lightly or mildly. So in rural America, estimates are, or the Census Bureau says that there's close to 65 million people across the country who live in a rural community. And what we know about rural communities is that those populations are more likely to live below the poverty line. A quarter of the rural population are children. We also know that these are communities that have a tough time holding on to resourced primary care infrastructure, a lot of workforce, a lot of professionals, and that there are transportation challenges, all sorts of challenges with broadband, all sorts of challenges with mental health in particular, seeing higher suicide rates among youth in rural communities. And so there's no shortage of issues to solve for in rural America. To get back to the question around what is the Rural Health Transformation Program, as Kelsey mentioned, this is a program that was established under H.R. 1, which is the One Big Beautiful Bill Act. So the bill that went through Congress over the first half of the year and was signed into law in early July. And within this bill was a provision establishing a program to the amount of $50 billion to be distributed to states over the course of 5 years. So it has a start time and an end time, 2026 to 2030. And there's a lot underneath this program that states are going to have to be engaged on and paying attention to. First, it is $50 billion divided into two sets. The first category is $25 billion is going to be given or allotted to states who have a quote unquote approved application as determined by HHS, the Centers for Medicare and Medicaid Services. The second $25 billion, so the second half of this funding pot, is pretty discretionary. And so states are having to put together at the time of this recording as comprehensive application as possible to stake out what their vision is for transforming healthcare in their rural communities. And that's a huge task to be able to vision cast for, with maybe 6 to 8 weeks for any given state to put together. And by the way, many of the states are doing the daunting task of soliciting public input. And so when Kelsey is talking about some constituents who are feeding into different policy processes happening at the state level, but by and large, most states have gone through a public comment process to solicit from their communities, what do you want us to do with this funding if awarded? And what would you want in your communities? So they are working at warp speed to submit these applications. And at the end of the year, we will see which states were allotted what amount of funding. And it will be important for people in their states to be engaging with their governor's offices, to be engaging with their departments of health, in order to see how their state leaders and officials are actually implementing reforms that they promised they would take up in their application. So it's going to be a long slog. People should be engaged. It's a ton of money at stake for a lot of communities. We often talk about Maine as an example, where this kind of funding could have a real impact on the ground level. States like Alaska, for instance, Alaska has a lot of unique challenges, a lot of Alaska Native populations, et cetera. And so how are they going to be approaching this funding opportunity, et cetera? And I think this just underscores the point earlier, which is rural communities and rural healthcare is not a monolith. Like, you're going to need to figure out what works for your population, and people should be as engaged as they can be in order to make sure that those visions for how to use and apply this funding responsibly, conscientiously in their states is coming to fruition.
Kelsey, anything else to add?
The one thing that I would add to that kind of addition is this pot of money, as Lisa said, is also unprecedented with the sheer amount of opportunity that states have to use this to respond to their unique challenges that residents in their rural communities face. There is most likely never been this level of kind of support and infrastructure support, especially flowing into rural communities. And I think about, so I live in rural Kansas, grew up in rural Kansas. I experience rural healthcare in a way that is, and accessing rural healthcare in a way that's different than folks in Washington might experience accessing rural healthcare as folks in Maine or Alaska. And so I really think about all of the opportunities for states to really be responsive to the things that we know that they've been hearing from their rural communities. And this is an opportunity where maybe resources haven't existed for them to move things forward. This is a huge opportunity for states to really take that and run with it, as Lisa said.
Thank you. I know you're continuing to do that work of listening to the communities and that idea of then amplifying that voice into policy solutions. What are some things that you've heard as you are embarking on this project and thinking about the diverse communities that exist in rural healthcare? What do potential solutions look like or ideas that have come up through listening?
One thing that's come up that we have both been pushing for as an organization and we've seen states really taking a hold of is this idea of transforming rural healthcare and leveraging patient-first care, or sometimes known as value-based care strategies, to recognize the unique challenges of quite literally just delivering and paying for care in rural communities. Like we've talked about geography, we've talked about the fact that the volume of people just coming into your clinic is not the same as a large metro area. And states have really been embracing this idea of challenging the status quo, maybe, and saying, we're open to all ideas. Throw them at us. We want to hear them. And so what that really looks is doing things like changing how we're paying for care. So maybe looking at prospective payments rather than payments based on every single patient to allow providers time to really sit down with the patient. Things like care coordination, as we've talked about, rural communities really struggle with just resources, both from a lack of resources and also just accessing those resources because of the geographical landmass in some of these states. And so really helping to support coordination of maybe you have an illness, you need an antibiotic for it, but also you got that illness because your house is not clean and you don't have running water that is safe for you to be drinking in whatever rural area. And you didn't have someone to drive you to the doctor when it started to get bad. And so now you're in the emergency room or whatever that might look like. And so really saying, okay, what can we do right here, right now to help you access these resources that are going to keep you healthy and keep you from coming back here or coming back to the emergency room, and instead meeting folks where they're at. I think workforce is a huge component of that as well that we've really seen states looking at, and how they can use new innovative models of leveraging different types of practitioners or different models of practitioners to really be meeting patients where they're at and giving them the resources that they're asking for when they need them.
Have you noticed that we brought the example of Alaska versus Nebraska, Kansas, you could name it whatever, however you want to, but I suspect the communities in the different states are looking for different things. Have you found specific requests through those different listening sessions with different communities?
I would say that states have all taken very different approaches to this. And so some of that has been through written comments. Some of that has been through listening sessions. Some of that has been different levels of engagement. And I do think that we have seen states really taking a look and recognizing that there are very unique differences between rural communities. Mm-hmm. We've seen several states have even asked folks, how should we define rural? What do we mean when we're using the term rural? And how do you think that should be designed for our state? And so I think states are really trying to take a look at this and say there are a lot of needs in these communities because they have been historically underfunded, historically underserved. And in that, I think are making conscious efforts. I know Washington, for example, made a conscious effort to engage tribes and say, hey, we know that many of our tribal communities live in rural areas. what is it that your community might be needing that is different than a rural community in another part of Washington. And I think that there's also opportunity for stakeholders and people to say, hey, this isn't working for me. There is a kind of period of implementation that requires states be kind of meeting the guidelines for use of funds. And so in that, we expect that there will be opportunities for stakeholders to engage even more. And so a really great opportunity for providers, for people, for community organizations to come in and say, hey, I know we talked about this 2 years ago, and actually this is not meeting our needs anymore. What can we be doing to change that? And so I think many states are also embracing that too.
I would say, so Kelsey's team has done work with another group of colleagues that we have on the research and community engagement team. And we've done listening tours and listening sessions in Maine, in North Carolina. We also went around Colorado. All of those states have very different populations. And we really tried to diversify the voices that we were hearing from. For example, we did a listening tour in South Carolina. And if it's okay, I'm going to just read a quote that we got from one of the participants at a listening session. First of all, we don't have a maternity doctor around here. You either got to go to Bramberg or Orangeburg. And Bramberg, I don't even think they deliver babies anymore. So if you're pregnant and you need to see a doctor, you can either go to Orangeburg or you go to Goldsboro or you can go to Columbia. Those are the 4 if there is anything, and there's nothing in Bramberg County to help you. So this is a rural resident in South Carolina ticking through, honestly, the mental gymnastics of what do I do if I am expecting? Where do I go to deliver? But also, how is this patient supposed to also receive regular gynecological prenatal appointments and care? And if you layer on top of that this is just like one profile of one person having this experience, how can the Rural Health Transformation Fund be a vehicle for bridging that gap in care? And so I think that's where our team tries to feed in is what are the ways that we can make sure that this funding isn't just backfilling hospital expenses and that it is actually going toward investing in sustainable models of delivery and models of payment that are going to give patients what they want, more time with their doctors. We want to be treated for our whole patient care, not just symptom by symptom. One of the patients that we had talked to in a recent focus group had mentioned, we were talking about the fee-for-service model, which is this like volume-based model where we effectively in the United States like to pay for things by service, which there's a theory behind that. And unfortunately, it's also driving up a lot of costs. But one of the patients that we had talked to had mentioned how this experience with a volume-based system has left her thinking about her healthcare being like a cafeteria where she just shows up in line and the cafeteria person like slops a piece of healthcare on her tray, moves down the line, slops a different piece of healthcare, a prescription for something. And so we've unfortunately dehumanized the experience of receiving healthcare. And if we can shift our way of thinking, challenge the status quo of this sort of like fee-based system into a more value-based payment approach or patient-first care approach, we can theoretically bring down the cost of healthcare, bring down healthcare prices, and make it work better for people so that they actually enjoy their experience with their physician or provider and actually get what they need out of the healthcare system as opposed to schlop.
Yeah, what a metaphor, because it does often feel that way. And I think the vision of value-based care is something different. And what you're bringing still is that patient voice in that I think we get maybe the terminology still isn't correct. If you go and talk to the community of value-based care and they're like, the value bin, like, what are you talking about? There's like such entrenched and historical harm that's been done that people view through skepticism. And because you're in the community listening, I feel like your power is actually capturing that a bit for people who are trying to figure this problem out. Have you encountered situations like that you're trying to amplify as well?
That totally resonates with us. And in our research, listening to people, we did do some messaging research that hit on that very point, which is language matters. So if you're going to talk about changing the healthcare system to one that is prioritizing care coordination, reducing wait times, treating the whole patient rather than an appendage or a symptom by symptom, how you frame that and what you call it is going to matter when you're engaging with real people, everyday people. And what we found is that resoundingly don't use the word value, right? Like people associate that with like bargain bin quality items that you go and get, like do you want a bargain bin paper towel or do you want like the name brand stuff?
Don't you want
right?
Bounty?
Like yeah, exactly. And so that's been an interesting thing for the work that I lead at the federal level, because we often talk about here in Washington, D.C., quote unquote, the Beltway. There's such an ivory tower. And I say that not so much disparagingly, but there is a missing opportunity to connect the dots between the policymaking and the wonkiness of what we're talking about and the real everyday experiences that patients are having with the system. And if policymakers really want to see change, they've got to talk about these things in a way that's going to resonate with everyday people, with voters, and that makes sense to them. Like, avoid saying the word value. We've embraced the term patient first care, but honestly, I think as long as you don't say the word value, you're in good hands. Quality over the whole person care, all of those terms can be really helpful and useful in painting what we want to paint as a picture for the ideal sort of state of healthcare.
Yeah, I think that's a great point. I don't know where I was reading this of just how listening and understanding patient voices is just being really clear about the problem, because you can understand why sometimes people's solutions might not meet the current constraints of the system, right? I want everything paid for when maybe a cancer drug is $40,000 per month. So insurance has to figure out how to pay for that, which means increased prices for others. But the problem is it's too expensive. Right. So whatever solution we come up with, we meaning experts, policy, you name it, of the stakeholders who are listening to the patients, it has to make it more affordable, and that being a North Star and one of the key areas. And accessibility in rural healthcare is more important, more than so many other topics, because of workforce shortages and distance being a real barrier. And so many hospitals have closed their maternity wards in the last few years. And that's been a source of distress for so many people, because you're still going to get pregnant. If you're going to deliver, you want a safe place to deliver. And what does that mean to be innovative and create structures like that in rural healthcare? I think is an important question to answer. As we roll out this funding the next 5 years, knowing that some states might have 30 rural hospitals, some might have 90, knowing that it's actually a huge difference. What does it mean to be connected with the United States of Care or connected to patient voices through the channels or venues you've connected?
Okay, I'd love for Kelsey to feed into this. First, this is the Rural Health Transformation Program. During its inception, when Congress was going through the reconciliation process, they were talking about this as a hospital fund. But in reality, what they passed in law is this is not just for hospitals. This is for providers. And so providers can look like all different types, right? It's not just hospitals. So that's point one. And I think what that means is that opens up the door to more diverse ideas, more diverse engagement between different types of providers and their state officials throughout this process. I would say is the funding is interesting because the discretionary part of the funding allocated can change year to year. And that is like a huge asterisk to be putting on these applications, right? You tell a state, apply, give us your vision, tell us what you're going to do to transform rural healthcare in your state, and we'll give you this money. But look, they're going to be asking for states to resubmit every year a state report on how it's going. And if a state is missing milestones, it's very possible that state will see the next year's funding diminish in response. And so that is interesting because I think what that says to me is, number one, if you're a provider in the state that's getting money, engage with your state officials, do whatever you can to make sure that you are helping the state meet its milestones, meet its vision. Be prepared if it turns out that there are fluctuations year to year in the funding, and make sure you're working with your state to ensure that there's a plan for if the state does not receive funding to the level it expects for a second year or third year, like what is the state's plan to make that up? How can we as a stakeholder on the ground be engaging to keep things at least moving forward? This is really unprecedented investment in rural communities, and our hope and what we're reading in the releases from HHS right now are they really want states to go big and think about this in a really transformational way. But recognizing that the funding can fluctuate is like a an interesting bump in the road if any states happen to fall into that trap.
And also
but
the
Kelsey,
context on, I think, the Medicaid funding dropping, which is part of the reason for increasing the funding this, because state officials were concerned about rural health. So knowing that this is a 5-year fund in the context of losing ongoing funding with that and states' difficult decisions on what does innovation look like in that context. Go ahead, Kelsey.
I'm so glad that you said that, because that was one thing that I was going to flag is for states to really be considering the time limitations and how do you get the most bang for your buck almost with this fund. Something we've been really encouraging states to be thinking about is helping to create some of that infrastructure for transformation that providers need. What administrative challenges maybe have providers faced that has kept them from transitioning to value-based care? Are they still doing paper charting? Do we need to be supporting EHRs in rural communities? How does that feed into how they're paid? What does their billing systems actually look like? And those types of innovations that may sound like a one-time kind of investment, but really will fundamentally alter the ability for providers in rural communities to operate in a way that is different and more responsive to their folks in their communities. And thinking about not using rural health transformation program funds to backfill lower payment rates to providers or push a cliff that providers may or may not be facing in rural communities just 5 more years out, because this will go away eventually. And so are you creating, or how do you keep from creating a problem that you'll just have to deal with later, rather than leveraging that money now to really sustainably alter the system in a way that allows for providers to also stay sustainable, knowing that many providers in rural areas could be hit hard with Medicaid funding cuts, and communities themselves hit hard with maybe losing access to coverage completely or otherwise.
Any words of advice for clinicians, healthcare professionals who want to be part of the change, but maybe are not fully part of this mechanism of they're actually practicing? Rural health care is a little different and that it's not always like that. But going back to that question of what does advocacy and look like for clinicians, healthcare professionals who are maybe witnessing these stories firsthand?
Great question. We and our partners in our states partner with provider organizations all the time to bring their perspective to the table on these issues, because we recognize, and I think community advocates have faced and understand the barriers that folks face in engaging. It's in the policymaking process. It's confusing. Providers can help bring a really helpful voice to that conversation. And so as Lisa said, there are going to be many opportunities for states to be making sure that they're doing what they said they'd do. And so weighing in, I would imagine that nearly every single provider organization in every single state, so association, I should say, so like the American Medical Association or the specialty-specific associations in states, weighed in on rural health transformation program outcomes or what they'd like to see in that initiatives. And so that is one opportunity if providers don't already think about or know what they could be doing. Also, really encourage providers to be reaching out to their legislative bodies. Legislators tell us all the time, they're like, I want to hear from my constituents. And providers are constituents. Also, it doesn't just have to be your patients. And so reaching out, sharing what you're hearing from your patients to amplify the voice of patients can be something that is so helpful and is oftentimes missing.
That's a great call to action, because I do think there is a pervasive sense of powerlessness because the systems are so big, unfortunately. And I don't think the change is felt positive for many folks in our healthcare system. So I think call to action on engaging with your professional societies. So maybe re-engaging with that and contacting your legislators, because that's also another piece I don't feel like people are always engaged in, but a great call to action for people who do hold varying amounts of power. But as clinicians, we do hold a specific kind of power. So I think that's great.
But the two things that really strike me about your question are, number one, I think providers have an enormous amount of work on their plate, and provider burnout is very real. And we should have started by just saying thank you to you. Thank you to other providers out there who are in this field and have dedicated their career at a really uncertain time in our nation's history and around healthcare right now. Major expression of gratitude. And this is going to look different across the country. It's 50 states are going to be implemented. If all 50 states submit an application and all 50 states get an approved application, there will be some measure of money coming into the state. And some states are going to do this very differently. If you are a provider who has an active professional society, great, go there. If you have a real, the spirit moves you and you want to talk to your legislator, go for it. I would say one really easy ask that you can also be making of government officials right now is for information, for transparency, so that there's a understanding about what's happening and that information is filtering down not just to providers and peers and colleagues, but also to just all stakeholders in the state. Some states are doing better than others, and also not lost on me that states have a ton that just fell in their lap with this bill and this new law, but good to make sure that they are very much aware of the appetite for transparency and information.
Do people contact you directly with the United States of Care, or do you specifically work with just the community and legislature?
Great question.
Yeah.
So we have a table that we call Voices for Real Life. And so this is a table of folks that are team members on our research and community engagement team lead, that are folks who have experiences with the healthcare system and want to share them, point blank. And so that can look like consumers, that can look like providers, that can look like community leaders who are amplifying voices of the folks that they work with. And if you're like, I don't know that I want to talk at the national level, but I do want to find my state folks, you can also just email us. And I just had a call with a woman last week who had reached out with a story that she wanted to share and wanted to get involved in her own state. And it was a state that we didn't work in, but I was able to connect her with the folks who we do chat with and say, hey, liaising is something that we are also always happy to do. And I know that our partners and states specifically are always happy to get that kind of outreach as well.
Kelsey and I are also on LinkedIn. You can get our email addresses from our website, unitedstatesofcare.org. So feel free to reach out if there's a way that we can help make some connections and answer any questions on this.
Thank you so much, Kelsey and Lisa.
Thank you.
As always, thank you for listening to Healthcare for Humans. If you've found any value in this podcast, I have two quick requests. One, please leave a review in the podcast app that you're listening to my voice in right now. It really helps others discover the show. Two, share this episode with anyone who you think might benefit from it. For easy access to all our episodes and to support the podcast, visit www.healthcareforhumans.org. There you'll find our content clearly organized by topics, countries, themes, to help you choose what to listen to next. Until next time, this is Dr. Raj Sundar, reminding you that culturally responsive care leads to better patient outcomes. See you again soon.